All right, and this is the last two steps in the nursing process, implementation and evaluation. So implementation is, so we talked about interventions at the end of that last PowerPoint. Implementation is those steps that you're going to implement as the nurse. It's the fourth step in the nursing process. Any treatment is based on clinical judgment and knowledge that a nurse performs to enhance patient outcomes. That's what implementation is. It should be evidence-based, and it can be direct or indirect care. Direct are treatments performed through interactions with patients, and indirect are performed away from the bedside but on behalf of the patient. There's different domains of nursing practice, and this was done really in a long time ago. I can't remember what year, but by Patricia Benner. And she's still pretty relevant as a nurse theorist. And she talks about the novice to expert way of thinking at the bedside. But the domains of nursing practice include the helping role. Nurses are helpers. Nurses have a teaching and coaching function, diagnostic and patient monitoring function. They have effective management of rapidly changing situations, administering and monitoring therapeutic intervention and regimes, sorry, I can't speak today, monitoring and ensuring the quality of healthcare practices, and organizational and work role competencies. Many times we have standardized interventions, and those are common interventions for common health problems. And just as an example, if somebody is short of breath, acutely short of breath, then the first thing that I want to do is get them in a better position to breathe. Elevate their head of the bed, sit them at the bedside. I might have them cough and deep breathe. I might use an incentive spirometer, and those are common interventions. Then there may have clinical practice guidelines and clinical protocols. And so those are evidence-based tools that hospitals will implement, that when I take care of this patient after gallbladder surgery, these are the clinical practice that we expect. This is the progress we expect to happen. There may be standing orders. And so standing orders are orders that are approved by the physician's board and are there for your use. So, like one of the things that's a common standing order is that if they are acutely short of breath, you as the nurse can put on oxygen on the patient, but they cap it off at 2 liters per minute. Now, if sometimes there will be other standing orders for if they have a fever or different things like that. Nursing interventions classifications, standards of practice, and quality and safety education for nursing. Those are all ways of practicing that help with our interventions. Implementing interventions involves critical thinking, and we've been talking about that process a lot, critical thinking and clinical judgment. And what you're going to do as the nurse is you are going to review all possible interventions, consequences of doing or not doing each intervention. But along with that, I didn't type this on here, but it does need to be relevant to your patient. Will it work for your patient? Determine the probability of all possible consequences, judge the value of the consequences to the patient, and apply intellectual standards. If the implementation process ensures efficient, safe, and effective nursing care, and there's 5 preparatory activities: reassessing the patient, reviewing and revising the existing nursing care plan, organizing resources and care delivery, anticipating and preventing complications, and implementing the nursing interventions. They also include, one of the things as a nurse is that you know the best practices, but you are an employee of the healthcare system. And so you are taking care of 5 or 6 patients when you're in practice, and that involves you need to get good at time management. So inadequate nursing time contributes to poor quality or patient care, and excess nursing time contributes to high costs of care. And so the organization weighs those things. There's three components to nursing care: physical, psychological, and sociological. As part of your implementation process, you need to evaluate equipment and supplies. What supplies or equipment do you need? Are they available? And do I know how to use the equipment? Can I safely use that? Is there anybody here who can teach me how to use that? And then you want to return any unused supplies as appropriate. Personnel. We'll talk about nursing care delivery models in a few weeks. But one of the other things is delegation, because you're one person as a member of a healthcare team. And so you may delegate. You may delegate to another peer. You may delegate to a licensed practical nurse. You may delegate to an NAP or UAP, a nursing assistive personnel, or unlicensed assistant personnel. The environment, is it safe and conducive to implementing the therapies? And patient safety is your highest concern. Provide assistive devices if needed, and you want to ensure that the furniture is arranged for their safety. So that, let's say you're going to lift them out of bed using a device, or you're going to ambulate them to the bathroom. You want to make sure that the path is clear, that they're not having to, either your equipment or you or the patient is not having to walk around bulky equipment and such. The patient, are they physically and psychologically comfortable? Control the noise, temperature, and lighting in the room, manage symptoms such as pain and nausea, and offer comfort measures. And all of that is so that you can implement your interventions. Anticipate and prevent complications. Stay alert for risks posed by a patient's illness and treatments. Be aware of condition changes, and some procedures pose risks. Identify areas of assistance when you need assistance. And the skills that you need to implement are cognitive skills, interpersonal skills, and psychomotor skills. Direct care includes activities of daily living, instrumental activities of daily living also. So activities of daily living are, what do I need to do every day? I get up, I take my bath, or I wash my face, I brush my teeth, I brush my hair, I get dressed. That's my activities of daily living, primarily. Then we add that the instrumental activities of daily living, things like shopping, meal preparation, house cleaning, running errands. So those would all be direct care implementations. Physical care techniques, life-saving measures, counseling. Teaching is also direct care. And one of the important things to bear in mind are the HCAHPS. And I'll have you look up what HCAHPS are. Control for adverse reactions and any preventive measures. So if somebody's at risk for a pressure ulcer, I'm going to turn and reposition them every couple of hours. Indirect care are nursing actions that manage the environment, such as the code cart. I need to make sure that the code cart, that the defibrillator is charged and that the drawers are stocked. I need to make sure that I have the right equipment that I need on the floor, that I have oxygen available, IV pumps, etc. Documentation is indirect care, but when we talk about documentation later, if you didn't document it, you didn't do it. So it's an important part of patient care. It's just indirect care. Communication. I'm talking to the families. I'm talking to the pharmacy. I'm talking to the physician. So all of that is also indirect care. It may lead to direct care, but it's indirect care. Delegation is indirect care. Infection control, handoff reports, and environmental safety management are all indirect care. Delegation of care is when I delegate the care to another individual. And delegation means that I ask somebody, usually the UAP or NAP, to assist with some of the care tasks. That's the person on the unit. I could be paired with some places that you might be paired with an LPN that you're working with, and then you delegate what is within their scope of practice. And I could be partnered as well, and that could be part of the delegation. And now, achieving patient goals. Want to implement interventions to achieve goals and outcomes. We want to coordinate our care and time management. We want to set our priorities. And another important thing is adherence. And adherence is the patient's ability or willingness to follow the plan of care. Evaluation is the final step in the nursing process. Like I said at the first of these PowerPoints, the nursing process is fluid. It's dynamic. It's not a static process. And so while it's the final step, it leads to revisiting the other steps. And what we're looking at in evaluation is, was the goal or outcome met or not? Critical thinking is key to evaluation. You're going to look at the results. You're going to compare. Okay, well, I said I wanted them to lose 2 pounds by the end of the week. And did they lose 2 pounds? What was their weight before I started? What was their weight now? I said I wanted their respirations to go below 24 breaths per minute. What are their respirations now? Was it met or was it not met? Recognizing errors, and sometimes we don't necessarily set achievable goals, or we maybe didn't do the right interventions for that patient. Understand the patient's situation, self-reflect, and correct errors. So examine your results. It's an ongoing process with each patient interaction. So evaluation is ongoing, is what that is saying. It's reflection in action. Be open-minded, keen, and use keen observation skills, and have a neutral perspective. Evaluative measures include observations, physiological measurements. I talked about respiratory rate, pain, different things that I can actually measure, urine output, weight, are physiological measurements. Collect over a period of time, and then recognize patterns of improvement or deterioration. As you gain experiences, you will start to recognize those patterns that happen when somebody is going to deteriorate. Compare achieved effect with goals and outcomes. So what was it that you were expecting, and what did you achieve, or what did the patient achieve? It compares clinical data, patient behavior measures, patient self-report measures, and they're collected before implementation, and then you compared those that were collected with the evaluation findings. If outcomes are met, the goals are met. Outcomes are statements of progressive, step-by-step physical, emotional, or behavioral responses. If met, there is no further need for the nursing diagnosis. If not met, the nurse should consider revising the goal or continuing the plan. Interpreting and summarizing the findings, just a couple of terms. Acute illness is rapidly changing conditions, and chronic illness, they're slow, subtle changes. Evaluations are patient-specific, and they're made on the basis of a close familiarity with each patient's behavior, status, and reactions to caregivers. And interpretation is, again, you're going to compare these findings with those you expect to see. So what did you see before when you determined that they had this nursing diagnosis? What are you seeing now? What would you see in other patients with similar problems based on the same care? What kind of barriers are you encountering with those findings? Recognize errors or unmet outcomes. So reflection and action occurs usually with a trigger event, like a breakdown in practice. Planned interventions were not completed. And sometimes that comes down to delegation. I delegated to the UAP to reposition the patient, but the UAP got pulled or has too many patients, and I didn't follow up with my delegation to make sure that patient got repositioned. So you may need to change frequency of interventions as well. Self-reflection and correction of errors, reflection and action and clinical learning are all parts of evaluation. Reflective reasoning improves the accuracy of making diagnostic conclusions, and reflection increases objective critical thinking. So when I am evaluating, then I'm looking, am I going to revise the care plan? So a successful goal, discontinue that part of the care plan. If it's unmet or partially met, I may want to continue that. I may need to revise it. I might need to modify my nursing diagnosis. I might need to change my interventions. I might need to change my goal. Maybe I need a longer time frame to meet that. And if, as part of that, you want to make sure that the goal is realistic and if the patient needs more time. As I've said before, reassessment happens. The nursing process is more circular and dynamic rather than a static plan. The nurse continually reassesses the patient for the need for the nursing diagnosis, revision of the goal, or implementations and improvements. And so you're reassessing all the time. Did these interventions work? If they didn't, let me try these other interventions. I will go back into that care plan at any point that it needs for reassessment. Collaborative and evaluate effectiveness of interventions. Patient-centered care. Patient and family should be involved in the process. We also have the healthcare team, as I said earlier. Patients are complicated in this decade, and so we need more than just the nurse and the doctor. In addition to effectiveness of nursing interventions, is the patient reaching a level of wellness or recovery established by the healthcare team? And then you're going to document your results. Documentation and reporting are essential component to evaluation. They should be consistent, thorough documentation of the patient's progress. And that is the end of this PowerPoint.